day when you leave. So please have your name tags ready. Also, I will say that some of you have some very, very interesting music and tunes and tones on your phones, your laptops, and your personal notification systems. If you could please put that on vibrate or silence, we would appreciate it. Because one of the things that I know I hate sometimes is when I'm sitting there and I think it's on vibrate and it's not, and then my phone goes off, and I'm all the way in the front of the room, and then I have to walk all the way out with the phone ringing because I don't want to turn it off. So if you could put it on vibrate or silence, we would appreciate that. So moving forward, utilizing concentrated insulins, a new strategy for the insulin resistant. Our speaker for this topic is Dr. Mark Stoller, Associate Professor of Clinical Medicine, Feinberg School of Medicine in Northwestern University, Chicago. He plays an integral role with NACE in developing a large portion of our diabetic programs. So please join me today in welcoming Dr. Stoller for our topic.
Morning, everybody. It's always nice to be in New York for a brief visit, and it's always nice to go home, too, so I'm looking forward to finishing this lecture on time. I always like to start a talk by looking at the title and just kind of explaining the title. Why are we talking about concentrated insulins? Well, it's because, as you all know, your patients are getting heavier and heavier and heavier. And as such, they're getting more and more insulin resistant, and it's taking more and more insulin to try and get them to goal, often with diminishing results. One of the problems that clinicians don't appreciate is that the larger the dose of insulin you have to administer, the less it behaves in the way you expect it to behave. So its whole absorption kinetics and dynamics change. And so concentrated insulins were developed as a means of being able to deliver smaller, more accurate doses of insulin that behave predictably. Now, that being said, I hate giving talks that are just about a single area of therapeutics, because that gives you no insight or understanding into when should I use this, when should I think about this, because many of your patients are not going to have access to these concentrated insulin preps because they're new and formulary restrictions apply. So what I want to do today is to kind of talk about using all insulins and when to use insulin, because it's clear we don't use insulin the right place at the right time. Meaning, we save insulin for dessert. We give our patients insulin at the very last part of their diabetes. We keep saving it. Well, when you think about every other disease you treat in medicine, where there's a deficiency, what do? You give the patient what they're missing. If they're hypothyroid, you give them thyroid medication, for example. Well, because insulin has been injectable, we've done everything we can not to give the patient what they can't make. And the bottom line is, you will never have an elevated blood glucose if you are not insulin deficient. So if your well-controlled diabetic patient comes in all of a sudden with an A1C of 8, it's not because of they're eating too much or they're not exercising. They cannot generate enough insulin to normalize their blood sugar. And so anytime glucose is up, the first thing is, my patient's not making enough insulin. What am I doing in their regimen that is not allowing them to do so? And sometimes you have to think about, well, duh, why don't I just give them insulin to make up for what they can't do? Here's my changer. This is the faculty that helped me put this program together, so I appreciate their help very much. And these are the conflicts for the faculty. And these are today's learning objectives. So again, just kind of framing insulin into what we do. We're going to see how concentrated insulins fit in. We're going to discuss the pharmacokinetic and pharmacodynamic, those are always intimidating words, how insulin works. When you give a shot of insulin, you expect it to work at a specific time of day and in a specific manner. We're going to talk about how the different preps work differently. And then whenever you use a concentrated insulin, it's confusing. It's U200. Do I need to adjust? It's U500. How do I deliver that dose? Are the pens different? And so we're just going to talk about getting you comfortable with using concentrated insulins. One of the other things we're going to talk about is December is usually donut hole month for a lot of our patients. And for a lot of our patients, they can't afford their insulin. And so we're going to touch upon how to use NPH and regular. There aren't too many folks old enough in this room to have consistently used old-fashioned regular insulin and NPH on a consistent basis. But as we'll see, they work. And so we'll kind of help you adjust when patients say, I just can't afford my basal insulin. So a few pretest questions. Just current confidence in your ability to identify your patients with type 2 diabetes who may benefit from using a concentrated insulin. Select your answer.
We could be married, or we could be married, and then we'd be happy, and then we'd be happy. Oh, wouldn't it be nice?
And number two, how often do you consider using concentrated insulin therapy in patients with type 2 diabetes who are not getting to target on their current insulin regimens? Choose your best answer. These are actually important questions because the agencies that fund CME look at confidence and practice development changes when they assess whether or not educational programs are worth continuing. So these are actually important questions to answer. All right, so this is an old study. The UK-PDS study came out in the early 90s, and it just illustrated what was wrong. When this study was done, all we had was metformin, sulfonylureas, and insulin. So we usually started patients on diet and exercise first, and then added metformin or a sulfonylurea, and then we gave them the one that they didn't take at the first time, and then we saved insulin for the very end. And this pattern has still persisted till today, where we're just waiting till the end to use insulin. Well, what we've discovered is that beta cell function is continuously disappearing over time in our patients with diabetes, actually disappearing long before they develop diabetes. When you're diagnosed with diabetes the first day, you've lost about 80% of your beta cell function at the time of diagnosis. Some of it restorable, most of it not. And so at the beginning, you're by definition significantly insulin deficient. And so this idea that insulin should be at the end where you've run out of insulin, well, actually you've run out of insulin at the beginning. And so insulin should be an option from the very start. The other thing this study showed us is that for every 1% decrease in A1C, you get a significant benefit. And there's a decrease in the risk of microvascular complications, retinopathy, nephropathy, neuropathy, which is really quite significant, much more greater than the impact on macrovascular disease. But what's so important, and why the concept of using insulin earlier is so important, is that as we'll see, there's a penalty you pay for bad control. So this is a study that just looked at, in the SOLVE trial, when did physicians start insulin? When did they finally give in and say, it's time to start? Well, the average A1C when physicians started insulin was about 8.9 or 9. That's not on the physicians, because when have our guidelines told you it's time to start insulin? At 9. So it's on us in diabetes because we've told you wait until the patient is bad before you think about starting insulin. And we often use other oral agents in piles, 1, 2, 3 agents before we even think about insulin. When clearly you need to start earlier when a patient is under poor control. Why is that? We'll find out in a minute. In patients with an A1C greater than 7, a 1-year delay in treatment intensification was associated with which of the following outcomes compared to patients who were at target? So patients not at target versus at target. A 1-year delay in intensification of treatment. Was there significantly increased risk for MI? Was there a non-significant increase in cardiovascular events? Was there a greater subsequent reduction in A1C? Or was there no difference in outcomes if insulin was initiated in those patients not at control? Choose an answer.
And she's always gone too long. Anytime she goes away, wonder this time where she's gone. Wonder if she's gone.
Well, actually, there's a penalty that you pay. So if you look at the patients whose A1C was not at target and who didn't receive intensified therapy within a year, there was a significantly increased risk of myocardial infarction, stroke, and adverse cardiovascular events. And that's due to something called glycemic legacy, which most of you probably haven't heard of. So we have two trials in diabetes, which were intensive trials, one with insulin in type 1s and the other this type 2 study we discussed earlier, just looking at what happens when the trial's over. So we know what we got during the study, comparing intensive therapy versus non-intensive therapy, but they then studied those patients for 10 years after the trial ended. And so like all people, when you leave them to their own devices, A1Cs just went up and were identical between the two groups. But the groups that were in the intensive regimen early during the trial had significantly less microvascular and macrovascular complications 10 years later, despite their diabetic control in real time not being any different. So there's good glycemic legacy. If you control a patient tightly at the beginning, they have fewer complications and actually better beta cell function long term. But just like there's good behavior, there's also bad behavior. So in those patients in this trial who did not have good control up front, there is a bad legacy which represents itself in microvascular and macrovascular complications later on, and also in worse beta cell function later on. So it's important to get patients to goal sooner and not give up on our patients who indeed have elevated blood glucose that's not coming down. So why don't we give patients insulin? You know, the old reason was it was an injection, and in the old syringes, yeah, it kind of hurt. It was a problem. But it's a much more emotional thing for patients than just you need to take this shot. Patients don't break down in the office and cry if you tell them they need an injectable therapy for osteoporosis or an injectable therapy for their rheumatoid arthritis. They're excited to get better. Well, we don't get that response. Patients excited when we say it's time to start insulin. And the reason is there's a lot of emotionality about starting insulin. One is, I failed. If only I had done a better job taking care of myself, I wouldn't need insulin. There's a huge legacy effect for a lot of your patients, especially your ethnic patients, because in communities where there's a lot of diabetes, and a lot of diabetes with complication, African Americans, Hispanics, Native Americans, your patient with diabetes has a mother and a grandmother at home with diabetes. And because of how diabetes was treated before, they likely have complications now. So patients can go, oh, my mother's had to start insulin and now she's on dialysis. My grandmother was on insulin and she had a stroke. So there's this negative connotation to bad things happen when you go on insulin. With the newer insulins, loss of independence isn't an issue because they behave according to how the patient lives their life. And obviously, hypoglycemia and weight gain are a big barrier on the patient and clinician side. So just simple show of hands, true or false? Insulin causes weight gain. True? False? Good for false, but you've heard the correct answer in the last program. So the reason is, it is false. Insulin does not cause weight gain. Food causes weight gain. Insulin has no effect on your metabolic rate. Insulin is merely an energy storage hormone. So that if you take insulin, and if you make the patient insulin sensitive with metformin or pioglitazone, and they overeat, they're going to gain weight. Plain and simple. It's doing what it's supposed to do. Also, if you take a patient who is poorly controlled and start them on insulin and improve their control, they're going to gain 6 to 8 pounds right off the bat simply because when their A1C was above 9, they were dehydrated, and they're going to reequilibrate volume, and they're not going to be spilling glucose in the urine. So weight gain with initiation of insulin therapy is common. Second true or false question. Insulin makes you hungry. True? False. It's false. Insulin in normal individuals is a satiety hormone. It tells you to stop eating. Why do patients think insulin makes them hungry? Because insulin resistance makes you hungry. The more insulin resistant you are, the more insulin you have to take. And therefore, patients associate the insulin with hunger. Insulin is a satiety hormone. What are the clinician barriers to initiating insulin? It's plain and simple. You don't know a patient's going to need to go on insulin until they show up at your door with their blood sugar uncontrolled, and you've got 12 or 15 minutes now to go through the whole initiation of injectables. So very often we get into this, okay, next time. You know, I want you to really try hard for the next 3 months, and next time we'll do that. The second barrier is, how many of you have an A1C in front of you when you see your patient for diabetes follow-up? Okay. How many of you patients see your patients for hypertension without a blood pressure cuff in the room? So if it's silly to think you could see a patient with high blood pressure and not know what their blood pressure was, isn't it equally silly to think that you could see a patient for diabetes for a visit and not know what their A1C is at the time of visit? It's impossible. And that's another barrier to initiating insulin, is you don't know how bad that patient is till they're out the door, and you have to call them and say, gosh, your A1C is 8.9, let's adjust your oral medicines and then we'll talk about it next time. Well, the next time, again, you don't remember it was 8.9 till they're there. So you need to have A1Cs real time to manage diabetes. Point of care A1Cs are so easy to do. They're reimbursed by Medicare. It's essential. These are just some of the other roadblocks. And again, the biggest barrier is we have a lot of meds now. There's a lot of things we can do. And so we keep piling pills on in our patients. Never take any of the pills away, even if they're doing nothing, before we get to insulin. So we have so many choices that we tend to defer insulin only because there's another oral medication that we can do. The whole issue with discomfort and fear of injections can be overcome in the office with a single shot. I mean, it's that simple. And so the importance of here's your A1C, it's time, we need to start. Then, if you send the patient away and say, make a follow-up appointment, go see a diabetes educator, it's not going to happen. They're not going to say, oh yeah, I really want to start insulin. Let me make that appointment next week with this person I haven't met. It's not going to happen. It's a then and now thing. So when should you consider insulin? Whenever your regimen for diabetes isn't working, whether it's early or late. If your regimen isn't working, think insulin. The second time is if you're so far from target that your next choice isn't going to get you there. There's nothing more potent in lowering glucose than insulin, plain and simple. So if your patient's got an A1C of 8.8 and you think that by adding an SGLT2 inhibitor or a DPP4 inhibitor is going to get them to target, it's not going to happen. And so you need to think the opposite. You need to say to your patient, you know what, let's get you on insulin, let's get your A1C down to target. Your beta cell function actually improves when your blood sugar is normal. And then let's see if we can add something and begin to talk about maybe taking the insulin away. But if you think that another pill will drop your A1C by 1.7, 1.8, we don't have that pill yet. I'd love to have that pill. And then secondly, liver function, kidney function determines what medications we can use. And then there are some other considerations. But the big point is if you start insulin, the patient must be able to adjust their dose, especially with basal insulin. That's key because you don't know what dose they're going to need. I can guess ultimately what dose they're going to need, but no one knows. And you pick a starting dose. If you say, well, come see me in 3 months and we'll see how your blood sugar is, it's not going to work. So patients need to be given a titration protocol that's individualized for them. The standard one that's recommended is 3 units of basal insulin every 3 days till your blood sugar in the morning is 100. Some patients, hypoglycemia is such a big worry, you may not want to do that. Other patients are so insulin resistant, and with our new concentrated long-acting insulins, you may not want to titrate every 3 days. You may go up by 5 units every week. It's kind of figuring out where the patient's comfort is. The bottom line is you don't have to have their blood sugar normal next week. You want it under control at your follow-up visit. Self-glucose monitoring is not for you. It's for the patient to see what happens due to certain behaviors and what's happening due to their injectable therapy. How many of you look at 3 months worth of blood glucose readings at a follow-up visit? You don't. You don't have time. It's not interpretable. The most important thing is that the patient is using those to adjust their insulin and see the consequences of eating, not eating, exercising, not exercising, and make appropriate adjustments. If you're going to use self-glucose monitoring to make therapeutic decisions at your diabetes follow-up, have the patient monitor their blood sugar 4 times a day for the 4 days before your visit and look at that data. Because in type 2 diabetes, it doesn't vary that widely. Type 1, you'll need a little more data, but we're really talking about type 2s here. So basal insulin can get patients to target about 60% of the time when they're not controlled on oral agents. But what you have to remember is that basal insulin is basal. Metformin is a basal agent. It helps control intermeal blood glucose. So a basal insulin metformin combination does not help postprandial hyperglycemia. If you don't have enough insulin to control your fasting blood sugar, what does that tell you about your ability to make insulin in response to a meal? It's also impaired. And so basal insulin without significant postprandial agents on board is going to be a problem. And your patients never check their blood sugars postprandially because they've done it once or twice and the number frightened them because it was in the 200s. And so, well, I don't want to check it, it's in the 200s. Besides which, I just ate, that's why it's in the 200s. You can't just have them do fastings. Your starting dose in a regular insulin-resistant type 2 is not going to be 10 units. You're going to start at 20 and go up from there. And the reason is these patients are very insulin resistant. 10 units is reasonable for type 1 new diagnosis, but not for the typical patient. And always think about basal insulin when your first 2 strategies haven't worked. We aren't talking about GLP-1s today. Those would also be a reasonable introduction into injectable therapy. But the bottom line is if 2 pills don't have you close to goal, a 3rd pill isn't going to get you there. It's that simple. And again, if basal insulin and oral agents aren't able to achieve targeted therapy, think about using a GLP-1. Or you'll hear at lunchtime about SGLT2s, which don't require any insulin around to act in type 2 diabetes. Or even giving them a shot of short-acting insulin at their largest meal, because 3 pills won't do. So this is how insulins work. The fastest acting insulin we have is inhaled insulin. I just see no use for inhaled insulin in the current time. We have our current rapid-acting analogs, which you're most comfortable using, but again, regular insulin, which is as cheap as $17 a month at Walmart, works well for postprandial control, but you can see its duration of action is 4 to 6 hours, as opposed to the 2 to 4 hours of our common rapid-acting insulins. They work the same as the rapid-acting insulins in terms of A1C control. It's just there's a whole lot more hypoglycemia with our older insulins. NPH was as close as we could come to a basal insulin before we had glargine and Dedimer. When you compare control with NPH-based regimens versus our basal insulin analogs, A1C is the same. There's just a lot more hypoglycemia. And so this time of year, for your patient who's on 60 units twice a day of basal insulin and just can't afford that much insulin, you can get a bottle of NPH at $34 at Walmart, and they take a dose of bedtime NPH that's less than their basal insulin dose, but it's what we have to do for that month or 2 till their insurance kicks back in. It's about $300 a bottle. And so for 120 units a day, that's a lot of money. What's glycemic variability? Again, this is something that's a new concept in diabetes and endocrinology, but a very important one. In diabetes, especially we just check fastings, patients aren't checking postprandial, there's a lot of glycemic variability from patient to patient. So you can take 2 patients who are both at goal with an A1C of 7, and one has a blood sugar that's just like this all day, and the other one is up and down and all over the place and having hypoglycemia. They're both at target, but the second patient is going to have far more long-term complications, both cardiovascular and microvascular. And it makes our therapeutic decisions confusing. So glucose variability is both fluctuating and unpredictable glucose levels. What do you mean by fluctuating and unpredictable? Unpredictable means that you can check the blood sugar 4 straight days and get 4 very different readings at the same time of day. Fluctuating means that on a given day, blood sugars may be up or down at any period. The one little clinical pearl I want you to take out of this particular slide is that if you see a patient who has a 60 and a 280 in the same week of fasting glucose, they are always having hypoglycemia overnight. Always. You're seeing rebound from hypo. If you're seeing a 90 to a 190, it means their dinner time meal is not being covered appropriately with your regimen, and their morning sugar is being affected by how high they are at bedtime. But if you're seeing the wide swings where it can be low normal and very high at the same time, they're always having nocturnal hypoglycemia. So there's 2 kinds of variability. There's variability between individuals and variability within an individual. So you prescribe insulin, so you expect it to work the same way every time you prescribe it. Well, number one, it can be very different between 2 different people. So in some people, basal insulin is a 24-hour insulin. In other people, it's an 18-hour insulin. You're expecting it to be 24 hours in everybody. It's not. And so you're going to have to use glucose monitoring to help you figure out why is patient A different than patient B. One, it's basal, one, it has a peak. There's also intra-individual variability, meaning the same patient is injecting their insulin the same way every day, and they're getting different results. And so sometimes it's important to say, you know what, let's have a visit where you give yourself a shot in the office. You know, bring your insulin in, let's just watch, just to make sure you're doing it the right way. That's really important with the once-weekly GLP-1s, because if they're not injecting those correctly, and half the dose is leaking out, that's about $80 that's leaking out onto their t-shirt and a week of lack of efficacy. So injection technique is actually really important. So greater glucose variability is associated with which of the following? Improved A1C over time, both hypo and hyperglycemia, predictable fluctuations in glucose levels, or increased risk for weight gain with insulin therapy, which is associated with greater glucose variability.
What's impossible they forgot. This world keeps spinning and with each new day I can feel a change in everything. And as the surface breaks.
So glucose variability, as I said, is not variable or not apparent from A1C. You have 2 patients here have the same A1C. One that you'd like to be and one that's going to be all over the place, yet they're both at target. It is more important to eliminate variability than it is to get a patient to target. So a patient who's at 7.4 and is not having any hypoglycemia is as well off, if not better off, than the patient who's at 7 on an outcome basis. The greater the variability, the risk of hypoglycemia goes up. And this slide doesn't show it very well. I think it's got one more click to it. But the worse your control, the greater your risk of hypoglycemia. That seems counterintuitive, doesn't it? If your patient's A1C is 9.5, you shouldn't worry about hypoglycemia because they're not controlled. Actually, those patients have more severe hypoglycemia. Part of it is because of hypoglycemic unawareness. The more frequent you have it, the less you're aware. But 2, they tend to be on 3 or 4 medications. And so their risk of hypoglycemia is because someone forgot to get rid of the sulfonylurea that's hanging around. It's not doing anything to lower blood glucose until the patient goes to bed and stops eating. And so one of the things we don't do in diabetes is we don't fire underperformers. If a drug isn't working in diabetes, we don't get rid of it. We keep it around and add something else. There's no other disease that we treat in primary care where if a medicine isn't working, we just continue it and add something else. So when your patients are beginning to get to multiple medications, go, their postprandial's 280. I've got them on a sulfonylurea. It's not working. Their postprandial's 280. Let's eliminate it and try something different. So elimination is an important component of getting rid of this variability in hypoglycemia. One of the problems in type 2 diabetes is the longer you're on insulin therapy, the incidence of hypoglycemia increases. And that's for two reasons. Number one, this piling on phenomenon that we talked about. And number two, the more you have hypoglycemia, the more you have hypoglycemia. One episode engenders the next. So let's put a face to this. Meet George. He's on a high dose of basal insulin. He's 55. He's a limo driver. He's in a state where you can actually take insulin and drive, probably Alabama. Type 2 diabetes for 10 years. His A1C is 7. He's on metformin, pioglitazone, linagliptin, and glargine 70 units BID. And with all that, his A1C is still 8.8. He checks his blood sugar once a day, and he's between 150 and 210, and he often forgets to take his evening dose of insulin, but he noted that his blood sugar is not that much different in the morning when he doesn't take it and when he takes it. So very insulin resistant. So it's clear George needs some kind of change in strategy. So which of the following basal insulins has the longest duration of action? In case you said, well, let's just try giving him a once-a-day dose. Which of the four is the longest in action?
Some folks are born silver spoon in hand. Lord, don't they help themselves, dog? But when the tax man comes to the door, Lord, the house look like a rummage sale, yes. It ain't me.
Well, these are the action profiles of basal insulin. So NPH was sort of a basal insulin. It was the best we had for a long time. It works between 10 to 16 hours, and its peak is usually 8 to 12, but can be as short as 4. So if you are going to use NPH in the donut hole, be aware of those dynamics. Detamir and glargine were the two basal insulins we've been working with for a long time. They are somewhat peakless, but not entirely. And although they are meant to be 24-hour insulins, in many patients they are not. They're 16 to 24. And so because of that, we've developed ultra-basal insulins. There's glargine U300, which is a concentrated form of glargine, which because of its concentration is an ultra-basal or longer than 24-hour insulin. And then we have degludec, which is the longest acting ultra-basal. It is not a concentrated insulin, but you can prescribe it in a concentrated form for those patients who require large doses. So its mechanism of action isn't due to concentration, but you can get it concentrated. And we'll make that more clear in a minute. What happens when you just give a high dose of basal insulin to a patient? It doesn't behave the same way. So when you give a big dose of short-acting insulin, it's no longer so short. So for example, if you're using one of the ultra-rapid short-actings and you have to give 30 or 40 units at a time, it then begins to behave more like old-fashioned regular insulin. For the basal insulins, the opposite applies. So for basal insulins, the bigger the dose you give, the shorter it becomes. So once you get about 40 units of glargine or detamir, it doesn't last the full 24 hours. And then, of course, you have the issue with, okay, if you want to use glargine in a patient and they need 120 units, the pen doesn't go up to 120. They have to inject twice. And so that's the other advantage for concentrated insulins. And also, there's more leakage. The bigger the dose you give, the more that leaks out, and it can't lower blood glucose when it's on the skin surface. So let's meet a 49-year-old woman. She's got a 12-year history of type 2 diabetes. She has hypoglycemia once a week. Blood sugars are about 120 to 180 fasting, 180 to 200 at bedtime. So she's going to bed high, but going low overnight. Her A1C is 7.8. She's on metformin, empagliflozin, and glargine 70 units at bedtime. What would be appropriate for her? Would you reduce the dose of basal insulin? Would you switch her to prandial insulin 3 times a day? Would you just move her insulin to the morning? Or would you change her current basal insulin to glargine U300 or degludec U200? What's the best strategy? So who would benefit from concentrated insulin? Patients who need more than one injection to administer a single daily dose. Patients who are on over 100 units of basal insulin. Patients who need more than 25 units of rapid acting before each meal, or if the total daily dose is high. We won't talk about the pump, but I think the time to look at the concentrated insulins or ultra basals is when your basal insulin isn't basal. So like the patient we just discussed, who is having hypoglycemia in the middle of the night, she's not on an oral agent that's going to do that. Her basal insulin has a peak to it, and it's having a peak at around 4 in the morning. So George would benefit from an ultra long-lasting basal insulin since he's not taking his PM dose of insulin on occasion. Even though his blood glucose doesn't seem to be that different, it is. Let's meet Michael. He's on basal insulin, and it's not acting long enough, and we'll show you clues as to how to look for that. So he also is on metformin, empagliflozin, and U100 70 units at bedtime. His A1C has gone down from 9 to 7.9, despite increasing doses of insulin. It's kind of plateaued where it's at. He has hypoglycemia once a week, and his blood glucose is elevated after dinner, even if he has no carbohydrate in that meal. That's the clue. That's such an important clue, and that's why it's so important in a diabetes visit just to take a minute and take the data you've been given and go, okay, what'd you eat for dinner last night? And interpret what you're seeing in the blood glucose readings they gave you, even if it's just the fasting that morning, in the context of that dinner. Because if a patient says, I didn't eat dinner last night, I just went to bed, I wasn't hungry, and their morning sugar is 240, that's going to tell you a lot. Well, here, if you look at Michael's pattern, he climbs from dinner to bedtime even without carbohydrate. So what does that tell you? The only way he could go up is if he's not insulinized during that period of time. So Michael is a 20-hour basal insulin patient, not 24. And so the climb is not, oh, you're eating too much for dinner. The climb is his basal insulin is not covering him, and you either have to address that with splitting his basal insulin, moving to an ultra basal, or if insurance doesn't let you use one of the long-acting insulins, moving his insulin to breakfast so that at least it's working during the mealtime period. So we have two ultra long-acting insulins. One is concentrated, one is not, although available in a concentrated form. So because the U300 glargine is 3 times concentrated, the particle is smaller, and therefore it gets absorbed slower. You do not have to calculate. The injection device, the pen, does the calculation. So it's just automatic. Patient is on U100 glargine 30 units, goes on U300 glargine 30 units. The pen changes the injection. You don't touch it. That's why these insulins are not available in vials, to prevent that dosing error. U100 degludec is the longest acting basal insulin. It's multi-hexamers that dissolve slowly, so particle size is not the issue here. It's available in U200 form because patients who are very insulin resistant require large amounts of insulin. These ultra-long basals are less variable. So this is U300 glargine at the top, and you can see it truly is a much flatter insulin. U100 degludec, also very flat. The older basals, and that you'd say, well, that's NPH. No, if you look at detamir and glargine, both of them have significant peaks and valleys, even though they are meant to be a basal insulin. So let's meet a 53-year-old obese man, 9-year history of type 2 diabetes. His A1C is 8.9. He's on metformin, sitagliptin, and glargine 100 units at bedtime. His PCP wants to tighten control, but he's concerned about the volume of insulin being injected. So what would be appropriate at that time? Would you replace the sitagliptin with a GLP-1? Would you replace the basal with 33 units of U300? Would you replace the basal insulin with 100 units of U300? Would you replace the basal insulin with 200 units of U300 because he's not under control? Or would you advise the patient to recalculate his basal insulin dose following his switch to U300? So what's appropriate for this patient?
'Cause without you I was broken, but I'd rather be broke down with you by my side. So without you I was broken, but I'd rather be broke down with you by my side.
So again, the mechanism by which the concentrated glargine works more basal is it's just a smaller particle size, so it just gets absorbed slower because there's less surface area. When you look at the pharmacokinetics of U300 versus U100, it's very flat when you don't have to give a lot. So that's the green curve. As you have to give more and more, it too becomes less flat because the particle size gets bigger. So it becomes less basal the more you give. This is just an analysis comparing the concentrated versus non-concentrated glargine. As you can see in the top, A1C is no different. If you look at the number of hypoglycemic events, less with the ultrabasal. There's less variability. Why is there a difference in weight between the U300 and the U100? And anytime you see weight gain with insulin or other therapies, you always think, well, they're having hypoglycemia, so the weight gain's from what they're eating to correct the hypoglycemia. False. Patients don't like having hypoglycemia, so they gain weight because they learn to eat in anticipation of it. And to avoid hypoglycemia, they will eat more so that it doesn't occur. So the weight gain's not from the hypoglycemia, it's from the patient behaving to try and prevent it from occurring. So the basal insulins, the ultra-long insulins, degludec, but also the U300 glargine, can be injected at any time of day. Since they're totally flat, there's no rationale for bedtime, and it's much easier for patients to inject once a day in the morning. So morning is easier. It takes 3 days to reach steady state. So you don't want to change dose quickly. You have to tell your patient, don't adjust your basal insulin because you're having X or Y for dinner, as many of our patients do with their basal insulin, and they shouldn't. But this one, it won't make a difference. There's a little bit of an impact because it takes 3 days to reach a steady state. Your patients often have to go for colonoscopies. You just don't adjust the dose of insulin the day before. You have to adjust it the day before in anticipation of their prep. What's the difference between degludec, which is the ultrabasal, and U100 glargine? Again, works the same, much less hypoglycemia. So the new concentrated and ultrabasals are safer. This is just a trial, and you can see that there was a significant reduction with the ultrabasal degludec compared to the basal glargine, although A1C was the same. And that's why it's so hard to get these drugs on many insurance formularies because, well, A1C is the same, so we'll use the old one. What do you do if you can't get an ultrabasal and your patient's having nocturnal hypoglycemia on basal insulin? You move it to morning then, or you split it. Because again, many patients don't have access to these. How do you dose it? It's dosed the same as basals. So you don't adjust, the pen adjusts. So if a patient is on 50 units of glargine U100, you put them on 50 units of glargine U300, plain and simple. Then you titrate because some patients just absorb things differently. Remember that inter-individual variability? Some patients have more fat under their skin than others. Some patients' injection technique is different. And so with these small injection sites now, It may be that you get a little bit different dosing requirements, and so that's why you switch to the same dose first and then retitrate once you see how the patient responds. Forget a titration schedule. Customize it for the patient, but remember with the ultrabasal insulins, you don't adjust more than every 3 days. So Michael would do well with an ultra-long basal because his basal insulin just wasn't cutting it. So switching him to either Glargine U300 or to Degludec would be appropriate. So let's meet Laverne. Laverne is a patient who's going to need concentrated prandial insulin. She's a 45-year-old African-American woman. She's had her diabetes for 7 years. She struggled with obesity her entire life, but is unwilling to consider bariatric surgery. She's currently on 100 units of Glargine per day. Her dose of aspart insulin, short-acting, 25 to 35 before meals. She's on 1,000 of metformin, and her most recent A1C is 9. Her endocrinologist recommended U500 pens for intensifying her regimen, but she's confused about what does that mean? And she's afraid she'll take too much insulin because it's 5 times as concentrated. U500 is the one area your patients can get into trouble, so that's why we're talking about it, even though most of you in here are too young to have ever used U500 when it first came out 35 years ago. But it's coming back because our patients are so morbidly obese. So when do you think about U500? When a patient's daily insulin requirements are over 200 units a day, or when you're having to give huge amounts of short-acting insulin in a single dose and it's not effective. So the problem is that it comes in pens and vials, and that's where the confusion comes. So these U500 should only be used in pens, period. Don't do it otherwise. Why? Because the pen does the calculation. So 25 is 25. If you give a patient U500, it has to be dosed in a U500 syringe. Because if they use a U100 syringe, what happens? 25 units is suddenly 125 units. And if they say, well, you know what, I can't afford the pens, I've got to use the syringes, then they've got U500 pens and U100 pens in the house, and they grab the wrong pen and a wrong syringe, and you've got dosing errors. So if you're going to use U500, you got to use the pens, which do the calculation for you. Hypoglycemia is the big issue with the U500 because it can occur long after your dose. It's not truly short-acting. But for Laverne, she would benefit from the U500 because you can now suddenly begin to give her much more insulin. You can up the dose quickly. The pens only go up by 5 units at a time, which would be the equivalent of 1 unit in the syringe. So you go up 5 units at a time, and the pen does the calculation. So for her, splitting her basal insulin into twice daily dosing will make that behave more predictably, and then titrating her U500 30 units at a time would be appropriate. And again, she doesn't have to do the work, the pen doesn't do the work. I don't believe in all U500 regimens. It's just a little too complex for patients. And you know what happens with type 2s who are on 5 shots a day. The adherence to 5, most days it's 4, 4.5. Sometimes you get all 5. 1 shot often gets missed, and without the basal insulin, they're going to have more variability. So, take-home lessons about concentrated insulins. What do we know? Our basal insulins are fine. You know, what we're using has been fine, but they have their limitations. They're not always basal insulin. They don't always work for 24 hours. And there's variability in their pharmacodynamics and duration of action. And so the new concentrated or ultrabasal insulins remove that glycemic variability. Again, it's a smaller injection site, so there is less variability simply from that. Again, the pens do the calculation. You don't have to calculate. The patient doesn't have to calculate. Just the pen does the work. And that's why they're only available in pen devices. Again, even though they are similar insulins, they're not 100% identical to the current basals, and you may have to titrate doses up or down. And I've had a few patients when I've switched them to the ultra basals where their glycemic control just wasn't as good. It just deteriorated. And those are patients who need to go back to the basals. And again, U500, pens only. And I think it's a strategy you should be comfortable with because we're just facing an increasing number of patients who are so insulin resistant that we have to give doses of insulin we weren't previously comfortable with. A couple other take-home lessons. Once daily dosing in the morning for our ultra basals is fine. There's no rationale for bedtime unless it's easier for the patient. Think about U500. And concentrated insulins may be a cost-effective means of delivering higher doses of insulin with fewer daily injections and less glycemic variability. And I think they're going to be an increasing useful tool as they become available to our patients. On the flip side, for our Medicare patients who simply cannot afford many of these newer concentrated insulins, get comfortable with short-term use of NPH and regular, knowing that the patient and you're going to have to be more vigilant for hypoglycemia. So a few post-test questions. Confidence question. After hearing this information, how comfortable or confident would you be in your ability to identify patients who would benefit? Choose your answer. Good. I mean, it's good that there's a growth in confidence. These are, the more you drive the car, the better it works for you. And I think that they're a good tool, and it's good to see growth in confidence. How often will you consider using concentrated insulins in patients who are not achieving treatment target with standard insulin regimens? Great, and I think often or always is appropriate. I'm never an always guy, but I may think about it and dismiss it. But I think it's just having an open mind to, you've got a new tool in the toolbox. All right, in patients with an A1C that was not at target, a 1-year delay in treatment intensification was associated with which of the following outcomes compared to patients whose A1C was at target? Choose the correct answer. And good, it is significantly increased risk for MI. Think negative legacy. The longer you go without good control, the bigger the long-term price. All right, greater glucose variability is associated with which of the following? Choose best answer.
I'm 15 for a moment, caught in between 10 and 20, and I'm just dreaming, counting the ways to where you...
All right, it's both hypo and hyperglycemia. Good job. Which of the following basal insulins has the longest duration of action?
Do you remember when we first met? I sure do. It was sometime in early September. Well, you were lazy about it.
It's the Degludec. Very good. And again, 49-year-old woman, 12-year history of type 2 diabetes, episodes of nocturnal hypoglycemia 1 time a week. Drops fairly low. Her blood sugars are 120 to 180 fasting and 180 to 200 at bedtime. Her A1C is not at target at 7.8. She's on metformin, empagliflozin, and the glargine at bedtime. What might be appropriate at this time? So there's sort of two correct answers here, and it's really based on the insurance company coming up with what's the correct answer. So for this patient, in an ideal world where you could choose any insulin, switching them to number 4 using one of the ultrabasals would eliminate the variability. On a practical basis, many of our patients will not have access to that, and so 3 is correct. So you have that option if the ultrabasal or ultra-concentrated insulins are not available. So really both are correct. One's ideal and one's real world. 53-year-old obese male, 9-year history of type 2 diabetes. His A1C is 8.9. Metformin, sitagliptin, glargine. PCP wants to improve his glycemic control, but is concerned about the volume of insulin being injected. What would be appropriate at this time? What's best answer? Okay, so the correct answer is switch unit to unit. You will probably have to then adjust the dose afterwards because he's not at target, but you don't want the patient adjusting their dose yet because you haven't taught them exactly how to drive this car. So 100 is 100. And with that, Deborah, I'm done. Any questions?
We are, and we do have questions. Of course. Thank you, Dr. Stoller. Okay. Please recommend a point-of-care instrument for in-office hemoglobin A1C, reasonably affordable, very reliable.
You know, I don't know which machine we're currently using in our office, but the reproducibility is quite good. It was very affordable because we got it when we were in private practice as opposed to being part of a healthcare system where every dollar mattered. But it's very reproducible and reliable. I just don't know the manufacturer, but it's something that you should really consider. And again, it takes 6 minutes. It's part of the vitals for a nurse seeing a patient. For Medicare, you can only do the test every 3 months. For commercial insurance, and this is part of the problem with follow-up on insulin therapy, your A1C equilibrates at 6 weeks. So 6 weeks, you can see what the impact of your treatment has been. Your A1C still reflects a little bit of the previous 6 weeks, but the majority is done in 6 weeks' time. So when you start a patient on insulin, or you're aggressively titrating, and they're not a Medicare patient, I bring them back sooner. So 6 weeks is a very appropriate follow-up visit because the A1C will tell, and let's face it, insulin therapy is a big deal. It's not like just prescribing a pill and saying come back. So 6 weeks for non-Medicare, 3 months for Medicare patients with point-of-care testing.
Okay. So one of the things that we can do, many of you may not be aware of, I can ask Dr. Stoller to contact his office and let us know, NACE know, the name of the manufacturer whose instrument he utilizes in his office, and then we can post that either on our Facebook account. So go to Facebook and or email us, and for our viewer at home that asks a question, we will get that information to you. Is there anyone here in the audience who uses a hemoglobin A1C device in their office that they would recommend that we could say as well? No? Okay.
I mean, patients look forward to knowing. I mean, that's part of the visit. They want to know, what did my A1C show? It's like, well, good morning. How are you? I'll have the A1C in a few minutes. They really want to know, and it gets them engaged and involved in their care.
Good question here.
I just had a question. If you're on a split dose of glargine, how do you convert it if you want to use a once-a-day glargine 300 or degludec?
Add it up. So if it's a total daily dose of 100 glargine, it's a total daily dose, single injection, 100 of the U300. But I don't believe the pens go up to 100 with U300. And so that's one of the reasons that the U200 degludec came up, is that you can give a much larger dose in the pen. So there still is a limiting factor of how many units per dose. Unfortunately, we don't usually have the luxury of both. So it's like, okay, so my patient can't use the U300 glargine, I'll just use the degludec. Usually you get one. One is on formulary and one is not. And so that patient may have to split if It's 2 shots otherwise. 1-to-1 conversion, once a day. Behind you, Deb.
Just one question from home first. What should be the reasonable blood sugar level before surgery?
That's a very nebulous question. You certainly want a patient's blood glucose going into anesthesia below 140. Again, with these ultrabasal insulins, where a patient's going to be NPO for an extended period of time, and they do work for more than 24 hours, the standard is, okay, the morning of surgery, you just give half the dose, but you may want to adjust the dose the day before down by like 25% just because of that slight potential for carryovers.
Here's your question.
Hi, my name is Trudy. I wanted to know if you could use insulin for patients who are insulin resistant but not diabetic.
No, because really the only rationale is to get their A1C down, and so if they don't meet criteria for that, there'd be no rationale for that. There is no real diabetes therapy approved for use in the insulin-resistant non-diabetic patient. Metformin is used off-label for 2 conditions. PCOS, we use it all the time. That's off-label. And for prevention of diabetes in patients with impaired glucose tolerance, again, not indicated but used. If you are truly going to use a medication to prevent diabetes and do not do this, it would either be pioglitazone, because it's the most potent reducer of insulin resistance and has favorable effects on the beta cell. Don't do that. Or a GLP-1 agonist, because it has the most potent effects on beta cell health. Don't do that. So the most effective thing you can do in the insulin-resistant patient where you want to intervene therapy is 10,000 steps a day and under 100 grams of carbs. And 100% adherence to that. That's the most effective treatment.
So question from home. This person would use NPH much more often if it was available in a pen version and more affordable. Do you have any suggestions? Because they're concerned about administration error for anyone, especially when there's a language barrier.
So that's the problem, is plain NPH is not available in a pen. It is available as part of 75-25 or 70-30. So that's a possibility for patients. I'm not a big fan of premixed insulin because of the hypoglycemia risk. If there's a big educational language barrier, dexterity error, you can always pre-fill syringes for a few days for the patient if they're not capable of doing that on their own. That's not an optimal strategy for storage, but that's the one drawback with NPH, is it's syringes. But again, we're really using NPH in those cases where a patient is going to temporarily be in the donut hole, or if you're going to use it, it's bedtime only, like we used to do in the old days when we just had sulfonylureas and not even metformin. You use sulfonylurea in the morning and NPH at bedtime, and hope for the best in terms of control. As a key part of the regimen, it's a little bit more cumbersome because of the hypoglycemia and variability. But you're right, if it was in pen form, it would be a slam dunk.
Yeah. Question here.
Dr. Stoller, what would you recommend blood glucose level for a patient who's in the immediate post-op period?
So, it really depends upon the surgery. Obviously, healing and infection rate is higher when their A1C is, or when their ambient glucose is higher. The problem is inpatient hospital management of blood sugar is a disaster even at my institution, just in terms of timing of dosing and ability to eat meals and that. And so from my perspective, avoidance of hypoglycemia is the greater goal in the immediate post-op period than making sure that their blood sugar is 120, just because immediately post-op there's so many things going on that could impact. Many people have looked at using GLP-1s in that setting in the perioperative period just because they turn on and off, but those studies have yet to really bear fruit in terms of becoming standard practice.
Question from home. What is the conversion for basal to NPH?
Oh, that's going to be sort of customized. It's not a one-to-one conversion. What I would say is if you have a patient who's on basal insulin at bedtime and you're going to switch them to NPH, I would probably use 2/3 the dose, just because of the increased risk of hypoglycemia overnight. So if they're taking 60, I'd do 40. You can always increase, but you really don't want to deal with the consequences of too much. So I would cut the dose by 1/3.
Okay. It is intuitively difficult to understand how an even longer-acting insulin, such as degludec, doesn't result in stacked dosing of insulin with the same time daily dosing, resulting in overdose of insulin.
That was my concern as well when it
explain?
was introduced, but it's just not seen. And so I have to think that the tail is low enough that it's not stacking. But that was my concern, but they're just not seeing it. You could see the comparison with hypoglycemia to glargine, and it's significantly less nocturnal hypoglycemia. So the stacking just doesn't occur, but I'll admit that was my big concern as well when these products were first launched.
All right. Are there any further questions for Dr. Stoller? All right, we're going to take one last question over here. We'll be good to go.
Hi, thank you. You didn't, in the examples that you gave, you didn't reference firing some of the oral medications, and you did mention that in your talk. Were they applicable?
That would be applicable too. So didn't really want to get into that, but in some of the patient cases that were there, were patients on a huge dose of insulin and metformin, that tells you that metformin is not an adequate insulin sensitizer in that patient. You may want to think about pioglitazone, which is a more potent insulin sensitizer, but high dose of insulin plus pioglitazone tends to give you more edema. And so it's more assessing and maybe just dropping the metformin because it's not doing anything. If a patient's on 120 units of insulin and their fasting blood sugar is 180, we never fire metformin. It probably should be dropped. It's just not doing anything in that patient. Sulfonylurea should be the first candidate to go. Second candidate, DPP-4 inhibitors, because again, they work for postprandial control. If a patient's postprandial blood sugar is 250 on a DPP-4 inhibitor, it means that mechanism isn't potent enough to accomplish anything. They're very costly. That's when you would think about, do I get rid of it and replace it with an SGLT2 inhibitor, or do I just get rid of it and think about prandial insulin? Those are both options. But you're right, some of those patients should have had medications dropped.
Very good.
Great, thank you much.
Join me in thanking Dr. Stoller for excellent presentation. There's so many questions that come about when we do this talk on concentrated insulins, but on diabetes in itself. So we know there are a lot of questions. We're currently going to break for lunch. We will return for those viewers at home at 1 o'clock. But also for those viewers at home, one of the things that you will see here is that we do have an exhibitor here, Springer Publishing.